So thank you very much. Again, thank you for the invitation, and thank you for the titles, because today I'm covering my favorite topics, I would say, lupus and pregnancy. I have too many slides, so just let me know about the movement so that I might present a little slowly. So when we think about pregnancy, about our diseases, we know these diseases predominantly occur in young female in their fertile age. Now we have improved the way we treat patients with connective tissue diseases, and so obviously the consequence is that our patients are fine and they want to have a family. And so we support them during pregnancy. But obviously, many questions arise when we discuss about pregnancy in a patient with a chronic disease. First of all, whether it is possible to have a successful pregnancy. But the immediate question is, which are the risks for the mother and for the fetus? Can the disease affect the baby? Or can pregnancy have an impact on the disease? So today I'm fine, but if I have a pregnancy, I might become very sick, and my baby could be very sick, so it doesn't make sense. And so we can discuss a little bit about family planning and pregnancy management. So I would like just to give a very simple answer to the question as to whether it is possible to have a successful pregnancy in patients with connective tissue diseases. The answer is yes. The majority of patients with rheumatic diseases can have a pregnancy. But the but is the most important thing. Here you can look the results and the data of our pregnancy clinic in Pisa. In Pisa, we run a combined clinic with the obstetrician. We started this clinic in 2000, and we regularly see patients, pregnant patients, and patients for counseling once a week. Here you can see data on more than 400 pregnancies. It's not strange that the majority of these pregnancies are in patients with undifferentiated connective tissue diseases, lupus and antiphospholipid syndrome. But what I want you to note is that in our clinic, where we do counseling, where we plan pregnancies, and when we follow the pregnancy with a multidisciplinary team, we have observed 33% of disease flares in pregnancy, and 25% of pregnancies have obstetric complications. Out of these, 12% are severe complications. So this means that the but is that these pregnancies are high-risk pregnancies. The clinical situation may require that pregnancy is postponed, so pregnancy needs to be planned. And in some cases, very few cases, unfortunately, pregnancy is contraindicated. So when we discuss about pregnancy, we need to see the two sides of the coin: effects of pregnancy on mother's health and the impact of the disease on pregnancy, so the occurrence of pregnancy complication. So let's start with the effects on the mother health. When the couple comes and they say, I would like to have a baby, I'm fine, what you discuss with the non-pregnant couple? You discuss about disease flares, you discuss about the organ damage worsening, obstetric complication, and in particular for mother's health, the occurrence of preeclampsia or worst HELP syndrome, and other possible complications. So what I'm going to do is to discuss disease per disease and give you some very brief information about the most common diseases that we follow during pregnancy, because we cannot say that each disease is the same. There are general rules, but for some diseases the situation is worse. And in lupus the situation is worse. In lupus, as far as flares are concerned, there are different data in the literature. Here you can see different publications in which you can immediately observe from the flares column that in some cohorts you have few flares, and in other cohorts you have many flares. This is impacted by two things: the way flares are measured during pregnancy, not easy, but also how the patient started pregnancy, as the number of flares is strictly associated with disease activity at conception. meaning that if the disease is well controlled at conception, the risk of flare is lower. In the PROMISE study, which is a more recent study, multi-center USA-based study, 26% of patients flared during pregnancy. Few of them had a severe flare. So I think that there is another message. Lupus can flare. Flares are related with the disease activity at conception. Generally speaking, these are not severe flares. Severe flares during pregnancy are not common, are less common than hematological flare, skin flare, joint flares. Flares occur always during pregnancy and after delivery. But most commonly, and those that we fear most, are flares occurring during second and third trimester. As we know, pregnancy at the beginning is an event where we can do very few for the fetus. So really we are only worried about maternal health, while during second trimester and third trimester, we have to care for the baby. And there are flares in the postpartum period, so we need to care for these patients after delivery. Flares, as you say, also in this study were mainly serological and cutaneous. So again, not usually severe flares. Risk factor for flares from all the data that we see in the literature, as you see, as I anticipated, disease activity at conception, as well as low C4, younger age, and steroid. And sometimes I see this as an indication of the fact that the disease is not very well controlled. If I have a patient who's fine on 20 milligrams of prednisone, this patient is not in remission. And if the patient is younger, we know in young patients the disease might be more severe. So, take-home message for lupus and for mother's health and counseling: pregnancy needs to be planned because the risk of flare is related with disease activity at conception. Ideally, the disease should be well controlled for 6 to 12 months before before conception. LL-DAS represents a good starting point. We have seen in our cohort that patients in LL-DAS have a good pregnancy outcome. And this is how we start in lupus. We have different diseases, and we will hear later on about undifferentiated connective tissue diseases. Simplified conditions is not lupus, still connective tissue diseases. We may think that since these are milder disease, pregnancy would go better in patients with CTD, and it is true. Although flares are seen also in patients with undifferentiated diseases, but in the majority of cases, they are mild flares. You can see that there are, again, risk factors for flares, and these particularly are active disease at conception. What I would underline, however, is the fact that UCTD sometimes are the beginning of lupus or another disease. So if this is the case, obviously during pregnancy a progression to a defined disease can occur. So I'm not saying that pregnancy is the cause of the change of the clinical picture, but I'm saying that this could happen. And so we need to be very wise and care and follow these patients, particularly when they have some manifestations or predictive factors for a possible evolution to a defined connective tissue disease. In our cohort, we have observed progression of 3 patients with UCTD to lupus during pregnancy. All 3 patients presented kidney involvement, and I have to say that these were early diseases. But the point is that these patients need to be followed even if the disease is a mild disease. Systemic sclerosis. There are few data on systemic sclerosis. For many reasons is rare, but also the age of onset of this disease, at least in the past decades, was after the reproductive age, so patients are a little bit older. But still there are data telling us that in patients with systemic sclerosis, well, there is no no really flare of disease activity. Some symptoms may worsen because of pregnancy, but skin disease and Raynaud's phenomenon tend to improve during pregnancy. The caveat, the red flag starts after delivery, as cases of worsening of the disease have been observed postpartum, particularly in patients with recent onset disease. So in systemic sclerosis, I would say that obviously the best is to plan the pregnancy when the patient is fine, but need to follow up the pregnancy after delivery for the risk of evolution. Now we move to diseases for which we have less and less information on mixed connective tissue disease, and we will hear there is a big issue also on diagnosis if you consider it's kind of a very difficult entity to be tackled, and even with classification criteria. The few data available in literature tell us the same things that I keep saying on the other diseases. There is a rate of relapse, but particularly we need to be very careful based on the type of organ involvement of these patients, as some patients may have a pulmonary arterial hypertension, and pulmonary arterial hypertension is a very severe condition in pregnancy related with high risk mortality for the mother and might be a reason for contraindicating pregnancy. In Sjogren's syndrome, we have little data available on maternal outcome. As always, we may expect, in a chronic disease, a flare can occur. But I can tell you that this is not my worry when I see a pregnant patient with Sjogren's syndrome. It might occur. It might occur that they may develop some hematological manifestations, but the big point with Sjogren's syndrome is the anti-Ro and the neonatal lupus. It is not indeed the fact that maternal health can really change, even if recently some data have been published suggesting that patients with Sjogren's syndrome during pregnancy may have some other conditions, some adverse events more commonly than the general population. Here you see, for example, adult respiratory distress syndrome, shock, and preterm labor. But I wouldn't say that this is really linked with disease activity. So the take-home message, as far as maternal health is concerned and the risk of flares is concerned for our counseling in these most common connective tissue diseases followed in pregnancy, is that disease activity at conception is very important. A flare can occur, and we know this because we expect the flaring, relapsing, remitting behavior of these connective tissue diseases. This can occur during pregnancy, but if the disease is stable, has a stable remission, at least for 6 months, better for 12 months, then the risk of flaring is low. And even in lupus, the most severe disease, the risk of severe flare is still low. So you need to be very careful when you see a patient with a connective tissue disease and you counsel the patient because they come and they tell you they want to have a baby, to assess disease activity and tell her now is the right moment for your disease to try to conceive. Be careful for patients with early disease, as patients with early disease, being UCTD, being systemic sclerosis, may show a different clinical profile. They can do this outside pregnancy, and this can occur in pregnancy. And in pregnancy, every event has a biggest weight and a different repercussion on maternal and fetal health. As far as damage progression is concerned, we know that our disease are associated with damage. In lupus, damage is renal damage, and unfortunately, when the patient has a renal damage, whatsoever the cause, here we discuss about lupus, this has an impact, pregnancy has an impact on kidney function. So where patients have a renal function deterioration, during pregnancy this could worsen, sometimes in a reversible way, sometimes in an irreversible way. The presence of proteinuria is not a contraindication for pregnancy. Many of our patients with kidney disease have residual proteinuria. Just be aware of the fact that due to kidney hyperfiltration during pregnancy, proteinuria will probably increase during the second and third trimester. And this will put us in the position of a differential diagnosis between a physiological increase of proteinuria, a flare of the kidney involvement of preeclampsia, which which is not always easy and sometimes may overlap. So this could be an issue, but having proteinuria is not a contraindication for pregnancy. Sometimes a contraindication for pregnancy is pulmonary hypertension. Recently in London at the Congress on Pregnancy, this was discussed. These are very difficult patients who take drugs that are not allowed during pregnancy, so they have to stop the treatment for pulmonary arterial hypertension, which worsens very early during pregnancy. So in my experience, we are not so heroic, and we tend to contraindicate pregnancy in patients with pulmonary arterial hypertension, even though in some centers, some of these patients have been followed. And in addition, just to give you a hint, where there is a disease damage, there are more complications for maternal health. Here you can see patients with lupus and damage, whatever, any kind of damage, and you can see that those patients on the left side with damage have more hypertensive disorders, have more adverse outcomes during pregnancy. So having a damage is a bad thing. So damage should be evaluated and taken into consideration when you draft your risk evaluation at the time of counseling, so that you inform the couple about the risks and you define the follow-up that you will follow for your patient and how you will assess pregnancy, how often you will see these patients, and you can also empower patients in understanding what's happening and, for example, searching for a visit not just saying, oh, it's pregnancy, I'm this because I'm pregnant, I'm swelling because I'm pregnant. No, because there is a disease. So the other point of view is the one that refers to pregnancy. And so let's discuss about pregnancy complication. Abortion, intrauterine death, growth restriction, preterm delivery, neonatal lupus, and preeclampsia are the type of pregnancy complications that are more commonly observed in our patients. You will have noticed I've left behind antiphospholipid syndrome, and this I've done on purpose because antiphospholipid syndrome would require an additional presentation, and it's really a story itself on pregnancy, but it is, I would say, known to everyone, so I focused on the other diseases. So what can we say about lupus and pregnancy? Well, we can say that lupus has an impact on pregnancy outcomes. I'm fine, I have lupus, my disease is in remission, I've been in remission for 2 years, I'm on drugs that I can continue when I'm pregnant, but I have lupus. Has this an impact on pregnancy? Unfortunately, the answer is yes. It is yes in a general view, because if we look at the data on lupus pregnancies, we see that pregnancy loss is more common, is 1 in 5 pregnancies in lupus patients, while it's 1 in 10 pregnancies in the general population. There is a high percentage of stillbirths, 2 to 4-fold increased risk of preeclampsia, and approximately 25% of pregnancies in patients with lupus and in preterm delivery. So these are the data. Obviously, as we've heard this morning, what is my lupus? Lupus is a different disease. So there are mild lupus and there are severe lupus. So this is where what we tell to a patient with lupus, but then we have to get into the specific characteristic of our patients so that we can graduate the risk during pregnancy for the patient. It's like buying a dress and then going to have the dress adapted to ourselves. So what we can say again is that there is a correlation between disease activity and pregnancy outcomes. If mom is good, the baby is good. So why having a very well-controlled disease activity is good? Because this has an impact also on the baby's health, not just on the mama's health. So it is very important, and this is clearly shown in this data from our group. Again, our other colleagues have shown that lupus disease activity is linked with obstetric outcome, where active disease really brings worsen pregnancy outcomes. Having lupus nephritis is also a risk. So about 50% of patients with lupus in my cohort have had lupus nephritis. And even if lupus nephritis is not active, here you see data from previous nephritis, you can see that just having had lupus nephritis is bad for preterm delivery, for even preeclampsia, even if the data are not, the P is not significant, but you can see the numbers and are different. And also when eclampsia occurs earlier in patients with lupus nephritis. And the earlier preeclampsia occurs, the worse it is. When lupus nephritis is active, well, there is no story because you can see that the situation is even worsening. So lupus nephritis is bad, shouldn't be active. If it is there, we need to tell to our patients, you have lupus, there are risks, and your risks are higher because you have a history of lupus nephritis. Renal damage, as I said, is a problem because it will worsen in the woman, but unfortunately is not going to make any good to pregnancy. So I have lupus, I have renal damage, I'm going to go into dialysis, I don't mind, but I want to have my baby. This is not true. If the renal insufficiency is severe, luckily nature protects us because fertility is reduced in patients with renal insufficiency, but if pregnancy occurs, as you can see, the chance of going home with a baby is very low. So it doesn't make any sense to have a pregnancy in a patient with lupus and renal insufficiency. This will probably end very badly for the mother and for the fetus. Disease damage has an impact not only on maternal outcomes, but also on obstetric outcomes. So a patient with damage is a patient who has an increased risk of worse outcomes for the pregnancy. So lupus, I think it's very clear what happens. What about the other diseases we have covered? If we go to undifferentiated connective tissue diseases, the live birth rate is good. The pregnancy duration, you see, is very good, is ranging between 36 and 39 weeks. Very early preterm is very rare in these patients. Small for gestational age babies are not common, and preeclampsia is not so common. High percentage of cesarean section, we may discuss why. Well, this is the literature, but here you see a red. There is a but in CTD, and the but refers to patients with early and undiagnosed disease, meaning that if a patient has a CTD which is active and not diagnosed, this patient is diagnosed during pregnancy with an active disease, there is a higher risk of poor pregnancy outcome. So the early diagnosis I was speaking about lupus in reality is a need for all our diseases, even the milder diseases, because it has an impact on the life of our patients, for example, on pregnancy planning. If we go to systemic sclerosis, we can see that patients with systemic sclerosis have a higher risk of developing gestational hypertension and having cesarean sections with respect to controls. They have also a slightly increased risk of miscarriages and intrauterine growth restriction. And as far as CTD are concerned, the little data available in the literature, you can see the two most recent studies, a multi-center study, monocentric cohort and multi-center study, show, different rates of obstetric outcomes. In a prospective data collection, the one published by Radin et al. In 2019, you see that the outcome of pregnancy is rather good when a pregnancy is very well monitored and is planned for these patients. In Sjogren's syndrome patients, as I was saying, my worry is neonatal lupus. Is the transplacental passage of anti-Rho antibodies is not really the disease and the impact of the disease on the outcomes. And here you can see different rates of adverse pregnancy outcomes, but obviously related with the maternal health. So my message to my patients is that indeed Sjogren's syndrome is not a big issue, is not a big problem during pregnancy, but the disease needs to be very well controlled, and anti-Rho antibodies are a problem, even in those patients who have a systemic Sjogren's syndrome, so not just glandular manifestations. Neonatal lupus, just to remind you, is a terrible condition. It's very rare. 1% of anti-Ro carrier patients present this type of complication. It's not related with diagnosis, but it is related with the presence of these antibodies. So I just touch it on Sjogren, because in Sjogren we expect more commonly to have anti-Ro, but we do have these antibodies in CTD and in lupus as well, sometimes in rheumatoid. I mean, these are transversal autoantibodies. And as you know, and as you see, this is a complication that is linked with a high mortality, but for most of all with, let's say, an impact and a burden on the baby, and very often these babies needs to be paced for their life, because the effect on the baby's heart is irreversible. Antiphospholipid antibodies, as I said, I'm not going to discuss about this condition, but I just want to highlight the fact that just the fact that a patient has antiphospholipid antibodies is a bad prognostic factor for pregnancy, as we know that the presence of antiphospholipid antibodies, not of the syndrome, increases the risk of pregnancy complication. In our cohort, in patients with antiphospholipid antibodies or carriers of antiphospholipid antibodies, you can see that there is an increased risk, for example, as you see, not antiphospholipid there, of preeclampsia and of small for gestational age babies. And consider that in our cohort, all these patients, particularly if they have a triple positivity, so if they have a high profile risk, if they have lupus anticoagulant, we give low dose aspirin, even if they don't have a diagnosis. So risk factors for pregnancy outcome in connective tissue diseases can be summarized as the impact of active disease, the presence of lupus nephritis being in remission or active, the presence of damage, particularly renal damage for patients with lupus, the presence of antiphospholipid antibodies. Obviously, there are also other conditions that may have an impact on the pregnancy outcome, maternal age, and very often our patients have babies at late age because before, when they were young, they had to fight the disease, and hypertension is a risk for everyone, and obviously high-dose glucocorticoids. And these also reflect probably a bad control of disease activity. Very briefly, what about drugs? In our experience, 80% of patients followed for pregnancy are chronically in treatment and take a treatment during pregnancy. Patients are scared by drugs, by treatments during pregnancy. They don't want to take drugs. They want to stop everything when they become pregnant. It is very dangerous to do so. So a big part, not just of my counseling, but of my speaking with my patients in the clinic, is telling them, if you become pregnant, when you want to have a baby, this drug can be continued. So they are confident that they can control their disease activity, and that the treatment is really needed to control disease activity, because if they flare, it's even worse than taking Plaquenil or azathioprine for the control of the disease. My advice to you would be to discuss of pregnancy as soon as possible, as early as possible with your patients, even before they come to the clinic and they tell you, I would like to have a baby. Because if you understand that there is a plan for a family, you may want to choose a treatment to maintain the patient that should not be stopped when the patient has a wish of pregnancy. So you are fine. The patient is fine on a treatment that can be continued, and we do have treatments that can be continued during pregnancy. And you don't have to stop a treatment and then see what happens, and then maybe the patient flares, and then maybe you say, okay, now is the right moment. Because the time and the clock goes, our patients become older, they come to have babies older, and the disease may flare. So my advice is think about the right treatment very, very early in your management of a patient with a chronic disease. And use hydroxychloroquine, as data show clearly that the use of hydroxychloroquine is associated with a lower incidence of adverse pregnancy events, and these are data again from our cohort. So is it possible to have a successful pregnancy in a patient with a connective tissue disease? Yes, but there are many aspects that we need to consider when we counsel our patients, when we discuss with the couple, when we plan pregnancy, and when we follow the pregnancy. We can improve pregnancy outcomes by planning pregnancies, by assessing disease activity, organ involvement, damage, treatment, and autoantibodies during the follow-up of the patient and before conception. We can improve pregnancy outcomes with close monitoring and with a multidisciplinary care. Are we there yet? Are we happy with this? I would like to share with you, very briefly, a work that has been done within the European Reference Network, the ERN-RECONNECT, where we have done, with also other colleagues, work on a transversal working group on unmet needs for clinicians in the field of pregnancy and family planning. And we are not there yet. As even we discuss a lot about all these possible activities, still we face many problems when we are in our clinic. We felt, and the results of this survey showed, that there are still problems of communication with colleagues. Not always is possible to have an obstetrician in our hospital. Maybe they do have lots of things to do, and we need to work on this. Lots of centers do not have predefined organizational pathways, which I strongly suggest, because we need to know what we want to do and when this has to be done. Not everyone is expert, so we need to educate colleagues to follow pregnancies, and obviously we need to do this in the same way in the different countries. With this, I would like to thank the colleagues taking care of the pregnancy clinic at our university, our team for the pregnancy clinic, and all of you for your attention.